Ladies and gentlemen, the topic of today's talk is computational fluid dynamics and chronic rhinosinusitis. I'd like to thank the organisers for inviting me to speak today. Work of this nature requires the collaboration of several organisations, including Sydney's Westmead ENT, the University of Sydney, Melbourne's RMIT University, and funding from several sources, in particular the Garnet Pass and Rodney Williams Memorial Foundation. As one of the few research groups in the world specialising in this field, we also receive commercial funding. We are helping ResMed to design CPAP masks, ENT Technologies to design saline rinse bottles, and Optinose and Nasus to design nasal spray devices. This talk is a summary of our review of recent CFD literature. CFD uses mathematics and supercomputers to model the flow of air and liquids through complex structures. Despite the differences in anatomy, gender, age, and ethnicity, all human noses demonstrate high resistance and velocity at the nasal valve and inferior turbinate head, followed by distribution of bulk airflow between the inferior and middle turbinates. Most of the air conditioning occurs in the anterior half of the nose. In neonates, this occurs almost entirely within the nasal valve. At the peak of the nasal cycle, the congested side provides most of the air conditioning function. We're all familiar with the poor correlation between objective tests of airflow and patients' subjective reports of their own nasal patency. CFD has created new metrics that are much more accurate, particularly heat flux, which describes the transfer of mucosal heat to inspired air. This confirms that nasal patency is determined by detection of mucosal temperature rather than direct detection of airflow. One of our master's students, Richard, will present this work in another talk. Recently, CFD models have become more sophisticated by modelling the entire respiratory cycle. One of our PhD students, Kim, will present this work in another talk. This has demonstrated that during exhalation, the nasal valve restricts outflow to preserve air conditioning and to precondition the next in-breath, and that the posterior end of the turbinates recycles heat and humidity, which is yet another reason to perform turbinoplasty and not turbinectomy. The importance of turbinoplasty has been confirmed with other CFD studies. CFD has shown that in the nasal valve, butterfly grafts are highly effective, and as us clinicians have always suspected, spreader grafts provide little airway benefit in the majority of patients, their role being mostly cosmetic. We have shown that adhesions following sinonasal surgery have minimal impact on overall airflow, but significant local effects downstream to the adhesion site. And this explains why patients with a tiny adhesion often complain of much more obstruction than would be expected. Our master's student Herschel and our honours student Praveen will present these results separately. In normal individuals, there is hardly any airflow between the sinuses and the nasal cavity. This increases significantly following FES. New software being developed will allow surgeons to perform virtual surgery to determine the ideal procedure for individual patients. CFD has confirmed that most nasal sprays end up in the nasal valve, with barely 1 to 2% reaching the sinus mucosa even after surgery. By performing optimization experiments, we have increased this by 20-fold, and we've submitted a patent with Optinose for this technology. We have shown that saline irrigation can be improved with increased volume, increased force, and head position, and we'll discuss this in more detail in the next talk. Modeling the complete respiratory cycle demonstrates that particles circulate in the olfactory region across breaths, increasing exposure to the olfactory mucosa. CFD does have limitations, primarily around computer processing times. It can take weeks to perform a single experiment, but these limitations continue to be overcome. As a result, CFD continues to provide practical, real-world insights, resulting in tangible changes to clinical practice. Most importantly, complex work of this nature requires a coordinated group approach, and I'd like to thank our team and collaborators, without whom this would not be possible. In particular, I would like to thank the Garnet Pass and Rodney Williams Memorial Foundation for their generous support. Thank you.